Ladies and gentlemen, welcome to this session, this late session this morning. Without any further ado, let's just get started. I'm going to introduce Markus Skrifvars from Helsinki in Finland, who's going to talk to us about cardiac arrest and subarachnoid hemorrhages as a cause. Thank you.
Thank you so much for that. It's a great pleasure to be here and start off this session about subarachnoid hemorrhage as a cause of the cardiac arrest. Conflict of interest shown here, nothing commercial, nothing related to this topic. So, of course, what I'll try to cover is how often is subarachnoid hemorrhage or intracerebral hemorrhage the cause of the cardiac arrest if we see patients coming to our ED and we're thinking about ICU admission. Which are the factors that should raise our suspicion, where we should have a very low threshold to do a CT brain, and then finally, what should we do about these patients? This is a very nice physiological description of what actually happens when you get a subarachnoid hemorrhage. On the left, you have the ruptured aneurysm that causes a very quick increase in the intracerebral pressure, which will influence the brainstem's function, and then it will cause a gigantic sympathetic surge. And this will then influence the respiration, may cause respiratory arrest, and that will influence the heart via the mechanism of hypoxia. And this is probably 90 to 95% of the cardiac arrest. This is the mechanism why these patients get cardiac arrest after a subarachnoid hemorrhage. There is also the other pathway, the sympathetic storm, the increase of these mediators will cause a ballooning of the heart and will also, in some cases, may cause arrhythmias like ventricular tachycardia and ventricular fibrillation. And I think most of us will have seen cases like this, but this is not that common. It's the minority of patients who get cardiac arrest via this mechanism. So how common is subarachnoid hemorrhage the cause of a cardiac arrest? This is a systematic review we did about 10 years ago, going through all the literature published up until that time point. All in all, we screened the literature and found 13 studies where they had looked at in the cardiac arrest population, how common is subarachnoid hemorrhage as a cause of the cardiac arrest. So this is quite busy, but focus on the right-hand side where the figures for the proportion of patients with subarachnoid hemorrhage of all those out-of-hospital cardiac arrest patients that come to the emergency department. And as you will see, there's a great variability in the proportion ranging from a few percent up until almost 20%. And most of these studies are, interestingly, from Japan, and it's quite likely that it's just related to the fact that subarachnoid hemorrhage is common in Japan, and as a matter of fact, also in Finland, for that matter. Another more recent review also looked at this. They also included intracerebral hemorrhage as a group. The typical hypertensive intracerebral hemorrhage is less commonly associated with cardiac arrest, probably because the patients develop deep unconsciousness when the ICH is expanding, but the process is not that rapid that it causes the respiratory depression that is related to this massive event, which is subarachnoid hemorrhage and the subarachnoid bleed. So in this very nice review, if you're interested in this, do look at this review. They reviewed many more studies, up to 20 studies. This is quite busy, but if we then pool together the amount based on this, about 4% of all the out-of-hospital cardiac arrest patients have subarachnoid hemorrhage as the cause of the cardiac arrest. And again, the studies where the proportion is much higher are the Japanese studies. Then which factors should make you think that perhaps subarachnoid hemorrhage is the cause of the cardiac arrest? This is also nicely summarized in this review. So clearly, female gender seems to be more commonly seen in the patients with subarachnoid hemorrhage as the cause of the cardiac arrest. So this is something to keep in mind. Also, an unwitnessed cardiac arrest, more commonly so in the patients with a subarachnoid hemorrhage as the cause of the arrest. Then, shockable compared to non-shockable rhythm, clearly, as shown in the first figure, non-shockable cardiac arrest, PEA or asystole, is much more common as the initial rhythm than ventricular fibrillation. Then moving on to arrest duration, No major difference there, actually slightly lower duration of the cardiac arrest in the patients with subarachnoid hemorrhage. And then, very importantly, a return of spontaneous circulation prior to arrival into the hospital. Clearly a suggestion that it's more common to have a patient without return of spontaneous circulation, with actually CPR in progress when they are arriving in the hospital, and they have a higher proportion of subarachnoid hemorrhage compared to the group that has return of spontaneous circulation. So, of course, this is super relevant if we think about eCPR in these cases. And, of course, we've all seen cases where the patient is put on eCPR, and then they have the CT brain, and the disastrous brain bleed is seen. Then how about pre-arrest symptoms? Very good, difficult to study in the setting of out-of-hospital cardiac arrest patients, but we get some idea when we look at patients without a cardiac arrest but get a severe subarachnoid hemorrhage and call the ambulance, or their next of kin call the ambulance and explain the symptoms of the patients. So in this nice study, the authors listened to calls to the dispatch centers and compare subarachnoid hemorrhage patients with other types of neurological problems, like strokes, like encephalitis, meningitis, or more benign cases like just simple syncope or something. So what they showed was typical for the patients with subarachnoid hemorrhage, not very surprising, but neck pain, headache, nausea, vomiting, and sweating, more commonly seen in the patients with subarachnoid hemorrhage than those with other types of neurological problems. Then, when thinking about the acuity, how urgent did the symptoms feel, then not surprising, the headache was catastrophic, very quick. Within 1 minute, it went into the maximum impact, and also the headache was severe, and most of the head, it was felt in the whole head or more in the neck. So these are some kind of clues that could be used if the patient has been able to call the ambulance before they actually then have the cardiac arrest. So what do you then do? How to manage these patients in terms of diagnosis? This is from the ERC ESICM guidelines. If a patient comes in after a cardiac arrest, the key thing is, of course, to think about, is this a likely cardiac cause? And if that's the case, obtain your ECG and consider going down the cardiac pathway with considering doing a coronary angiogram and getting a cause for the cardiac arrest via that. If it's unlikely that the cause is a cardiac cause, then we should have a very low threshold to do a CT brain and to do a CTPA to look for the other causes, because they are the most common non-cardiac causes of the cardiac arrest. Then ECG was mentioned. I'm sure most of you have seen ECGs like this. So slightly unclear ST changes, like in this patient, AVR and lead number 3, but nothing in lead number 2 and nothing in lead number AVF. So clearly nothing that sort of anatomically supports, for example, in this case, an inferior wall myocardial infarction. So if this is seen, if there's ST elevation that doesn't really look right, doesn't fit into your typical pattern of a certain area of the heart being infarcted, this may be related to the sympathetic storm that the patients with subarachnoid hemorrhage get. Of course, the CT brain, you've all seen many cases like this, many CT scans like this. But bear in mind, there is the concept of pseudo-subarachnoid hemorrhage in patients who have a very high ICP, have brain edema, where the edema causes makes the CT scan look like subarachnoid hemorrhage when in fact it is not. Commonly seen after cardiac arrest, but in the more severe cases, and typically at 1, 2, 3 days, not so much in the very early stage, unless the patient has had a very long and prolonged resuscitation. So then finally, the outcome of these patients, based on these reviews, very poor, much poorer than the other types of cardiac arrest patients, not surprisingly. in the review that we did. Again, quite a busy slide, but please focus on the right-hand side. So of these few thousand patients, very few survivors, and none of the survivors survived with a good neurological outcome. So finally, some conclusions. The typical subarachnoid hemorrhage patient with a cardiac arrest is female, non-shockable cardiac arrest, unwitnessed cardiac arrest, may have complained of something urgent, headache, seizure, neck pain. If the situation mimics a sort of a cardiac-caused cardiac arrest where the cause is in the heart, but the ECG looks untypical, or the patient completely lacks the typical risk factors that we are used to seeing in patients with coronary artery disease and myocardial infarction, then keep this in mind. And also, finally, if the cardiac arrest is related to an activity with a sudden increase in the ICP, such as a bowel movement or having sex, then keep this in mind as a possible cause. Unfortunately, the outcome based on these published studies seems poor. We had one case about 3-4 months ago that was treated after prolonged time in the ICU, but in the end did not have a good outcome. Of course, the possibility of organ donation should be kept in mind. And with that, I conclude and happy to take some questions.
Thank you, Markus. Great talk. Any questions from the audience? While people are getting themselves geared up. And it's interesting, I did quite a long time on helicopters. There's a number of patients, or houses I go to, say, help my wife screamed, touched her head, fell down, collapsing, cardiac faulted, and cardiac arrest was really common. I suppose it's just a challenge, though. CT scans are cheap and pretty easy to get hold of. Oh, thank you. And so I tend to just, most of the cardiac arrests get a CT scan anyway, because it may show early loss of gray white differentiation or show a progression of disease. I just wonder whether we need to overthink it and just scan everybody. Thank you.
I mean, that's a great point. I guess the only group where you perhaps you would consider not doing it if you have clearly ST elevation, myocardial infarction, and you go for your PCI, for example. Yeah. But of course, the other thing as well is that I completely agree. When you have your cardiac arrest, you may fall, you may hit your head, you may get minor traumatic brain injury findings, small contusions, traumatic SAH. What do we do about that? Will that influence our treatment? That's another question. But I agree. We should have a low threshold. We have a system where if the patient has a likely cardiac cause of the arrest based on the view of the pre-hospital system, the patient goes either straight to angio or straight to the ICU. Yeah. And that, at times, actually has we've had patients whose subarachnoid hemorrhage is seen on the CT scan at 24 hours or 48 hours. But I agree, we should have a very low threshold for it.
Of course, there's a danger that you can end up putting someone in the wrong. Actually, are you treating
Definitely,
as a TBI slash SAH, or are you treating as a cardiac arrest?
Completely,
it's not quite the same thing. Any questions? Anyone think of any questions? Oh.
Okay, so the flip side then would be, instead of using this clinical situation to not do a CT scan, what about sort of these scanners that can go in the pre-hospital setting? So I recall the pre-hospital stroke systems where the scanners are in the ambulance. Tell me about that and your experience, Mark.
So as far as I know, there are studies ongoing on that in Germany, Norway, and I think it's mainly for stroke, where you can do something. You can thrombolize the patient, or you can get diagnosis to get them to the neurosurgical unit. For us in Helsinki, there's traffic is not a problem. It doesn't take too much time. It doesn't make much sense for us. Stabilize the patient and liaise with the hospital. And if you think this patient needs the CT scan urgently, they will take the patient straight to the CT scanner. So I don't think for us this is going to ever be the future, but definitely in countries like Norway, lots of fjords, lots of driving, difficult to get there, then this could be an option.
Okay, thank you. We're going to stay on time and move on next. So, actually, Danny, it's Tomoko is next. But I know you're excited, so thanks. So next is Professor Tomoko Fujii. She's from Australia, and where are you now? Japan, that's right, yes. And so she is going to be speaking about, hopefully, a controversial topic. Do we even need arterial blood gases? So thanks.
Thank you, Chris, for the introduction. I'm Tomoko Fujii from GK University Hospital, Tokyo, Japan. And today I'm going to talk about, do we still need arterial blood gases in the emergency room? So disclosures, nothing relevant to this talk. So the pulse oximetry was invented by Dr. Takuo Aoyagi, who was a Japanese bioengineer in 1974, which was a non-invasive method to measure blood oxygenation. And this invention led to the first commercially available pulse oximeter, and it is now referred to as the fifth vital sign. And every pulse oximeter worldwide operates on his original principles right now and isolating oxygen saturation levels from arterial pulse waveform. So pulse oximetry enables us to monitor continuously of arterial oxygen saturation, and it uses red and infrared light to estimate SaO2, and it rapidly detects hypoxemia and has significantly improved patient safety in the modern medicine. And generally accurate within 3% of error under ideal conditions in healthy population, but it can overestimate or underestimate in some conditions. So this is the point I want to mention in this talk. So SpO2 estimates SaO2 based on light absorption. And SaO2 is measured by arterial blood gas co-oximetry in general. And in most cases, these two values align closely, so there are no problems in general, but a significant SpO2 and SaO2 gap occurs under some conditions. And this is called a modified Bland-Altman plot. This visualizes the distributions of the bias, the gap of the two values. In this figure, we plot SaO2 in the x-axis, and we plotted the gap, SpO2 minus SaO2, on the y-axis. So if the data falls over the middle line, it means SpO2 overestimates SaO2. And if the data falls under the y-axis, it means SpO2 underestimates SaO2. And this is an observational study from Canada, I imagine. And they continuously recruited patients with severe sepsis or septic shock and collected data on SpO2 and SaO2 to see the agreement between the two levels. And in this study, they found mean bias of 2.75% in overall population. This was a small study. Overall population was just 90 patients. But they found that in the subgroup of patients who had SaO2 under 90% had a significantly larger mean bias with 4.92%. So this study conducted in the emergency room showed that hypoxemia significantly contributed to pulse oximeter bias. And in general, SpO2 overestimated SaO2. So the inaccuracy of pulse oximeter is very important because both underestimation and overestimation increase the risk of hospital mortality. In this figure, we plotted the gap, SpO2 and SaO2 gap on the y-axis, and we plotted predicted hospital mortality in the y-axis. So on the right-hand side, patients on the right-hand side had overestimated SpO2, and the patients on the left-hand side had underestimated SpO2. And this U-shaped graph showed, obviously, both groups was associated with the increased risk of hospital mortality. And Probably this may be because that many decisions we make in the emergency room rely on SpO2, like triage or whether to give oxygen or how to titrate oxygen, or even we admit the patients to the hospital or the ICU. So from this increased risk of hospital mortality, we can safely say that accurate measurement of oxygenation plays a key role in patient management. So we looked into the data to explore what were the factors related to this overestimation or underestimation. And I also put some additional information I gathered from the previous literature and also physiologically possible factors in this slide. So when we think about overestimate, hypoxemia, as we learned, and also chronic dialysis and CO hemoglobin can be related to the overestimation of SaO2. And for underestimation, mechanical ventilation, inhaled nitric oxide, methemoglobinemia, sepsis, or high-dose vasopressin, all of these are related to impaired peripheral perfusion, was associated with the underestimation of SaO2. And I would like to touch on this thing a little bit because we had an update news from FDA very recently. So during the COVID pandemic, the inaccuracy of pulse oximeter was highlighted again because this short report published in New England Journal of Medicine highlighted that the inaccuracy depends on the skin color and hidden hypoxemia, which was defined as SaO2 below 88%, despite SpO2 92 to 96%, occurred 3 times more often in black patients than in white patients. So this discussion had been in public for, I imagine, decades ago. But recently, FDA had published a draft of recommendation which said that if the manufacturer or industry wanted to test the device, the FDA recommend to test with increased sample size to enable the accuracy, to assess the accuracy in various population, and also to obtain data on skin color. So what about pH? We may be able to, test pH by venous blood gas. So this is a study conducted in the emergency room in Australia. They draw venous blood gases and arterial blood gases, and they compared the agreement between the two values. And they observed very small bias within this 246 patients. And there's a systematic review that pulled all those data that assessed the agreement between the venous pH and arterial pH, and they reported pooled mean difference of venous pH and arterial pH was just 0.033, which can largely, venous pH can largely agrees with arterial pH. But we have to note that venous pH is a little bit slightly lower than the arterial blood gas. So CO2, the systematic review assessed the agreement of CO2 as well. So they pulled all the data that assessed the agreement between venous PCO2 and arterial PCO2. And as seen in this plot, they found that studies assessed the agreement of PVCO2 and PaCO2 provided significant heterogeneity, and the 95 credibility interval ranged from minus 10.7 millimeter mercury to 2.4 millimeter mercury. So when we look this very broad credibility interval, we would think that the difference can be sufficiently large to influence our patient management. So probably venous PCO2 would not be so reliable. So what arterial blood gases would offer us? So it offers us gold standard accuracy because it directly measures gases in the arterial blood and definitely identify and quantify respiratory failure. And also it can provide us with physiological information, diagnose the type of respiratory failure and metabolic derangements, and we can tell that primary oxygenation failure versus ventilator failure from arterial blood gas. So do we still need arterial blood gases in the emergency room? So I would say yes, but we still need arterial blood gases, but not for all the patients, because non-invasive monitors have evolved and are very useful for continuous monitoring. And venous pH largely agrees with arterial pH, but yet they cannot fully replace arterial blood gases in the critical care. We need to obtain arterial blood gases when we need to know accurate levels of oxygenation and ventilation. Thank you very much.
Thank you very much. Thank you. Lovely talk, nicely presented. Any questions from the audience? Paul.
Hi, thank you so much for a wonderful and thought-provoking talk. So I'm a bit into machine learning and AI, and I was thinking, will there be a stage when we do not need to do arterial blood gases because they can predict it from other variables?
So I showed some clinical factors that might affect the overestimation or underestimation of SaO2. And some of them could be obtained from the arterial blood gas analysis. So we need to obtain arterial blood gas analysis to know the level of the like CO hemoglobin or methemoglobin to tell if it affects the value or not. So from the information we have currently would not be sufficient to tell the AI program to predict the discrepancy between the two values. But if more clinical data and more laboratory data would be, collected and repeatedly learned by the machine, and I hope they will predict the more accurate SaO2 in the future.
Thank you for an excellent talk. You mentioned briefly the issues with skin color and pulse oximetry. Would you say that when we are dealing with patients of color, we should have a lower threshold to get an arterial blood gas rather than rely on the pulse oximetry?
Yes. Many reports have repeatedly said that patients with deep skin color can suffer from the hidden hypoxemia, and they are at the risk of at the high risk of death when treated only with SpO2. So my answer is yes, but we don't know how the exact threshold of the skin color. There's no skin color 1, 2, 3, like some scales. It's not that simple. There are some scales to assess the type of skin color, but it's not so clinically usable scales. So if you think if you're faced with a patient whose skin color is dark, then I think it's more safer for you to lower the threshold to obtain arterial blood gas.
Maybe a call, if there are any manufacturers out there, if you've got two LEDs and they're measuring the blood, maybe we could measure this colour of the skin as well and correct for it. Just a thought. Really love to. I've got one question, or one comment and a question. I mean, so in our intubated patients, we've got another CO2 metric which might help, which is the end tidal CO2, which may have some correlation. But coming back to the venous CO2, okay, so you can't perhaps predict the true arterial CO2, and there's not a great agreement. But in a particular patient, is venous CO2 enough to look at response to treatment? So you get a patient comes in, you think they're narcotized because of COPD exacerbation, you start them on NIV, and then you monitor their venous CO2. Is that something, is there any data on whether or not the trend is reliable, even if the absolute value maybe isn't?
I'm not aware of such data, but probably we often use end-tidal CO2 to monitor the trend of the changes in the CO2 levels. I'm not aware of the venous gas
Something
data.
to think about.
Yes. Probably we'll be able to think that, yes.
Fantastic. Thank you very much.
Thank you very much.
In that case, staying on time, great pleasure to introduce Daniel Talmor from Beth Israel in Boston, who's going to talk to us about early prediction of ARDS.
Okay, thank you very much. So I'll kick right off with a question: why bother to predict ARDS in the emergency room? And the answers are here. So ARDS is potentially preventable. We have a lot of preventable issues in our ICUs: stress ulcer disease, pulmonary embolism, ventilator-associated pneumonia. All of these we can prevent. Why not ARDS? We know that we underutilize, and there's a lot of practice variation in clinical practices that may affect the development of ARDS. And early appropriate therapy may make a difference if we can find these therapies and if they even exist. So one of the first attempts at predicting development of ARDS in the emergency room was this score, the Lung Injury Prevention Score. And you can see that this is a combination of pre-existing diseases and risk modification based on the patient's individual attributes. And the LIPS score performed quite well. You can see that a LIPS score above 4, so 5 and above, gave you about a 10% incidence of ARDS, which is enough to intervene on. So a very good performance by the LIPS score. And a group came together, the Lung Injury Prevention Investigator Group, and decided to try to utilize the LIPS score to identify and prevent ARDS in the emergency room. And we chose as our target aspirin. So there had been at least 2 large data sets which showed that patients who were treated with aspirin prior to arriving in the ICU developed ARDS at a lower incidence. So we thought that that would be a potential first target therapy for prevention of ARDS in the emergency room. So we took patients in the emergency room, patients who had a LIPS score of 4 or greater, excluded younger patients or patients who were already receiving aspirin for one reason or another, identified them in the ED, and began therapy with aspirin in the ED. So they received 325 milligram loading dose, followed by 81 milligrams each day, 7 days of therapy versus placebo, and followed them up for the development of ARDS during their hospital course. Now, this study unfortunately did not show a difference between patients who received aspirin or not, but we were able to identify patients at a 10% risk of developing ARDS. So the LIPS score worked. It was able to predict development of ARDS, but the aspirin as a therapy did not work. So we decided to try to improve on our identification. So this was a study done later under the aegis of the PEDAL network. So the PEDAL network was the follow-up in the US to the ARDSnet. Instead of focusing on ARDS in the ICU, it became the prevention and treatment of acute lung injury network. And it was a collaboration between intensivists and emergency medicine physicians. So one target therapy was vitamin D, and we decided to test this in the emergency room. Other PEDAL interventions, for example, the ROSE trial, were ICU-based, but this was an emergency room-based intervention. And here we decided to try to enrich our target group. So patients in the emergency room who were at risk for ARDS were then tested for their vitamin D level. So if you had a high vitamin D level, you were excluded from the trial. We enriched our data set, or enriched our intervention by identifying patients only who had low vitamin D in the emergency room. So we improved on the LIPS score in that way. Again, this study was negative. Even though we were targeting patients with a low vitamin D level, they did not improve when they were given therapy by vitamin D, starting in the emergency room and progressing to the ICU. And in fact, if you look at the bottom graph there, patients with a low vitamin D level actually did a little worse when they received vitamin D therapy in the emergency room. So again, we were able to identify the patients. We took one further step in enriching our target group, but the intervention was still negative. So how could we further improve? So perhaps our LIPS score isn't good enough. And one hint to that came in this paper by Agrawal, which showed that if we add angiopoietin to our prediction model, that the LIPS score is improved. So by adding biomarkers to the LIPS score, we can improve its performance and better identify patients at risk for ARDS in the emergency room. Now, of course, there's tons of biomarkers for ARDS. This is a partial list, but there's new ones added every day. And I'm sure many people in this audience are aware that we're now using biomarkers to identify different subsets of ARDS. So largely, these are focused on identifying ARDS, which is hyperinflammatory, versus ARDS, which is hypoinflammatory. And you can separate these two groups based on the biomarker profile of the patient. And hyperinflammatory ARDS is associated with high levels of interleukin-6, interleukin-8, TNF1, low levels of bicarbonate and protein C. Hyperinflammatory ARDS is associated with higher mortality and fewer ventilator-free days. On the opposite end, hypoinflammatory, a different biomarker profile, generally associated with better mortality and fewer days on the ventilator. So when you take this approach to diagnosing ARDS, and phenotyping ARDS, you can actually go back and look at previous trials and see how they might have been problematic. So this is the simvastatin in acute respiratory distress syndrome trial. This looked at statins for ARDS given in the ICU, and you can see this trial was completely negative. But when it was reanalyzed, dividing the patients into hypo and hyperinflammatory ARDS, it actually looked like it was a positive trial. So hyperinflammatory patients who were given simvastatin had a better outcome than hyperinflammatory patients who were not given simvastatin. So this led to the idea that we have to re-examine all of those therapies that we threw out because of negative trials and try to build better target groups in order to identify specific subgroups of patients who may benefit from these therapies. Now, in this specific instance of statins for ARDS, the findings, weren't borne out in the reanalysis of the SAILS trial, which was a second trial of statins in ARDS, but there is an ongoing trial to try to look at this in hyperinflammatory patients. So the evidence even now is mixed for hyperinflammatory patients, but it's definitely worth going back and looking at. So why am I talking about phenotyping? Because we can also phenotype patients in the emergency room. And we went back and looked at the patients from the LIPS-A trial, so that trial of aspirin, and we decided to phenotype them based on this approach of hyper versus hypoinflammatory and see if these patients who were hyperinflammatory, or actually we didn't know, one or the other group, might have benefited from aspirin, and it was lost in the noise of trying to treat everybody. So we hypothesized also that we could identify these subphenotypes before the development of ARDS in the emergency room and help develop future interventions based on that. So we took the population of the LIPS-A trial. There were 376 analyzable patients because those are the ones we had the inflammatory biomarkers on. About 10% had developed ARDS. We looked at the existing models for latent class analysis, largely by Calfee and Sinha. We had large overlap in the biomarkers that were available to us, but we had some additional biomarkers. We were also missing some of what they had used, but by and large, there was overlap between the models. And when you talk about latent class analysis, it's very important to look at what they're actually including in their models, because this is still an area that's under development, and there is significant difference between different models. So we were able to identify 2 classes that seemed to be the best fit of the model. And it looked very similar to that analysis of hyper versus hypo-inflammatory ARDS, only these were patients who had just arrived in the emergency room and did not yet have ARDS. So we were able to identify inflammatory ARDS early in the emergency room. Equally importantly, these classifications remained consistent through the 3 time points that we had blood gases on. So you could say day 0 in the emergency room, hyperinflammatory is in pink there, hypoinflammatory in blue, day 1 and day 4. So by day 4, there were still significant numbers of patients who had a hyperinflammatory profile. Some had crossed over into hypoinflammatory, and there was a few patients who had crossed the other way. So there was consistent presence over time, and that transfer between the groups is also what we see in patients with existing ARDS. So we can continue to improve our models for detection of ARDS in the emergency room, and the hope would be that we can use this information. We can use these identifiable subphenotypes which persist over time to go ahead and identify new interventions to help prevent or improve the outcome of ARDS in the subsequent period in the ICU. So we really need to be looking at discarded therapies, and we need to be developing new therapies that can use this information to try to target patients early on in their course, because there is no doubt that targeting patients early in the course will give us time to intervene on the state that the patient is developing and improve outcome in the long term. So thank you very much.
Thanks, Professor Talmor. So I'm going to start off. This is a topic maybe close to my heart. So when I think about some of the questions, particularly on the early end of care, I think about the platypus. It's like my favorite animal. It's not a bird, and it's not a mammal. And that's all I could think about every time you put up the words hyper and hypo-inflammatory, because you're just potentially ignoring all the people who are neither, middle, or somewhere along this band of uncertainty. All the patients who are the platypus in the ED, which is essentially all of them when they come in undifferentiated. So I'm wondering what's your thought conceptually about handling that, both in the ED or the ICU, or really any time you're using the word hyperinflammatory ARDS?
Yeah. So remember, so I agree with you 100%, right? Human beings don't divide neatly into 2 groups in any scenario. So all of the patients who were included in the LIPS-A trial had already been pre-screened as being at risk for ARDS. So they were a LIPS score of 4 or higher. They were at some risk. So that immediately excluded most of the patients in the emergency room. We were only looking for a way to improve the risk prediction and try to see if there were subgroups in that LIPS analysis which may benefit or not. But, conceptually, moving forward, let's say you designed a trial of statins early in the course and you only gave it to the hyperinflammatory patients. Undoubtedly, there are some in the hypoinflammatory group who might have benefited but aren't going to be given the opportunity. There are some in the hyperinflammatory group who won't benefit but are being given it anyway. So that's, any time we try to classify patients one way or another, we're missing out on that middle ground, and we're doing the best we can with the information we have at hand.
Great. Questions from the audience? Paul?
Thank you, Daniel, for fascinating insights. And I'm just trying to get my head around what is it you're exactly predicting? Because in my mind, would it not be a much more direct prediction if you would directly predict who is going to have the hyperinflammatory phenotype when they develop ARDS, instead of looking at all the patients and dividing them first into hypo and hyper? Does that make any sense?
Maybe. So I'm not sure I understand the question, but I'll try. We're taking patients in the emergency room, the earliest possible point we could predict anything, and we're identifying them as hyper or hypo, but we know, based on the data there, that they will continue to be hyper 3 days later in the ICU. So we're predicting as early as possible what they're going to be, and hopefully designing interventions based on that prediction.
These are also patients that do not develop ARDS at all, right?
Some of them don't, yes. But
We might be better off predicting patients that will have ARDS and of that phenotype.
Yeah. So I'm presenting the state of the work till now. There's definitely room to improve on this. I think the LIPS score could probably be improved on as identifying the patients at risk. And then we would look again and see if we can classify those patients based on the hyper versus hypo-inflammatory.
Excellent, thanks.
Thank you very much. Congratulations.
Thank you.
In that case, we'll move on and introduce my last speaker, which is Paul Elbers from Amsterdam, who's going to talk to us about data science and how that's going to revolutionize our admission, I think.
Yes, thank you kindly, Ari, for that introduction. So I do a lot of talks about data and machine learning, and it's a real pain in the neck because this field changes so fast that we need continuous updating of these talks. So I'm from Amsterdam, from the Center of Critical Care Computational Intelligence. You might know us from the Amsterdam UMC database, the first freely available European database. I have a few biases. I work with a scale-up company called PacMed, and academically speaking, I am the chair of the ESICM data science section. Now, first of all, today is a very special day, not only because my hometown Amsterdam is turning 750, not only because today my favorite soccer team Ajax has turned 125 years, but today it is my birthday. And I love intensive care so much that I decided to celebrate it with all of you. Right? So without further ado, we're going to talk about AI in the emergency department. And we need to narrow it down. But if you want to learn more about this fast-paced field, there are many reviews out there. But today I would like to focus on predicting admission. And I'm going to talk about predicting who is going to be in your emergency department from the home. And also who is going to be admitted from the emergency department into your hospital. And that is probably necessary because, as you know as well as I do, emergency rooms are overcrowding. So while there is a lot to be said about AI in the ED, we're going to focus on the first bit, right? So self-triage and forecasting, dispatch, and a bit of triage. So now the first thing comes into mind, especially with all these large language models appearing, can we do a little more self-triage? And this is actually pretty feasible. It has been out there for a long time with initially simpler models, but this is a very recent, well, if I say very recent, then it's already 2 years old. It's probably not very recent in the field of AI, but relatively recent paper on the triage accuracy of symptom checker apps. So this is predominantly US-based, so most of you probably don't know these, except, of course, the NHS thing. And they do a pretty decent job, but of course, and you've all been playing with these large language models such as Claude, Gemini, ChatGPT. This world is going to change drastically. So there's already a systematic review out on the diagnostic accuracy, and there have been some benchmarking papers on the symptom checking capabilities of ChatGPT, and this is how they would typically test that. So it's basically the way you would enter this in your chatbot as well. It might not be advisable to do so, but this is what happens already, right? And are these chatbots any good at? Well, they're doing a pretty decent job across the board. I don't know if you can read it in full, but there's all the specialisms on the x-axis and the accuracy on the y-axis. So everything looks hunky-dory, except for the right lower corner, right? Emergency medicine. So these ChatGPTs are still pretty bad at diagnosing conditions that are important to emergency medicine. So moving to forecasting, actually a lot of work on this has been done in Finland for some reason. I think it's probably because they have a very well-organized healthcare systems, organized into regional networks, and they have a pretty good idea on when some of these hospital hubs are full. So they started with predictors based on the ARIMA algorithm, which is very often used in forecasting, and as you can see here, there's a significant overlap between the prediction and the real-world data. What stood out for me is that there's obvious predictors like day of the week, secondary care workload, and local public events. But even in Finland, the weather did not play any role in it. So I find that pretty surprising. And model calibration was good, and they improved upon their model because these ARIMAX is a relatively old technique. And they improved upon that by 15 to 20% by using later machine learning techniques. But a very recent paper tried a totally different approach by just looking at the GP electronic health records, so the general practitioners, and looking at the time of visits and the inter-event clustering of sequences. And they all put that into a big model, and then they could predict very well who was going to attend at the emergency department. This is something that is grasped my attention because it can probably be very easily implemented as long as your GPs, of course, have an electronic health record. But it could easily be scaled on a national level. So for dispatch, ambulance dispatch, there is going to be a revolutionary technology that is going to be in your cars, right? So if you have an accident, your car is going to be reporting what is the chance that you will need an ambulance in the first place and what kind of ambulance. This is currently out there, and it already has been implemented in some car brands. But there are also technologies that can be used by the medical dispatch center using multimodal data to classify what type of patients is going to be met at the road. And there are pretty easy inputs. You can see this in the pink, which will ultimately lead to an output after a long chain of machine learning tasks in the right lower corner, and it can predict either life-threatening or whether a delay in response is adequate, et cetera, et cetera. So it actually led to a substantial performance increase of 5, 12.5, and 17.5% of identification and stratification of patients. Now, I hear you say, can a large language model do this too? Well, of course. So large language models can do everything, right? So this is the large language model agreement with a paramedic panel. And It's pretty good. So it's probably going to replace some of us, or maybe augment us in the near future. So now, how about triage? This has been an extensive subject of study. Many trials have already been done in this area, and this is a review reviewing them, and these were already pretty good. But of course, now that we have large language models, people have also tried that. So now, how does that work? So this is from Mount Sinai, and it's basically integrating clinical notes and tabular data from the first hour of the electronic health record in the emergency department. And I think it has some pretty impressive characteristics, even with the so-called zero-shot tries. And if you evaluate that a little further, you can again compare that to triage nurses. So these are some of the prompts they would typically use. So on the left side is ChatGPT, on the right is Microsoft Copilot. And so I think these accuracies, it's not perfect, right? But I think it will be a great help. But it has to be said that the nurse is still better here, right? But very recently, so I think this is actually this February, yeah, I see it there. So this has been subject to a clinical trial. So here, Taylor and others looked at the impact of AI-based triage decision support on emergency department care. So this is not yet large language models, right? So these are simpler models, but they made a huge difference. So you see, so it is a before-after trial, right? So we have to take into account all the caveats that go with that. But on the left side, so in the white, you have the pre-deployment, and in the gray, you have the after deployment. And on the, I don't know if you can read it, but on the upper side is the proportion of patients that were characterized, so triaged as having a low acuity score. So that increased a lot, right? So between before and after implementation. And very interestingly, so the AI recommendation is the black line, right? So and the green line is what the triage nurses actually did. So based on input by the AI, they even thought their patients were less acute than the AI actually predicted. And what I found most fascinating is that the nurses plus the AI system, they performed better when evaluated by final dispatch than the AI system itself. And also, the hospitalization for low acuity patients remained low, between 2.5% to 4%. So it seems that this model is actually working, and it reduced the time spent in the emergency department. Well, not by a lot of minutes, as you can see, but if you multiply that by the number of patients, 170,000, it will save you a lot of time. Okay, so is this not all too good to be true, right? Well, I do think that this is the future. So we need to teach ourselves about using artificial intelligence throughout intensive care medicine, throughout the emergency department, throughout emergency medicine. But we have to also take into account that it will cost us a lot of money. So it should also give us great benefit. And the new AI Act that has come into effect now actually obliges every hospital to teach professionals, so the people that use AI, to teach us about how you can use the models, and also be very much aware that unanticipated events that have not been captured in the training of the model can break these models. So you should have a general distrust against them. And again, of course, overconfidence in these predictions can lead to resource misallocation. So as we have already seen in the talk by Tomoko Fujii about the blood gases, there are existing biases always in the data, and these existing biases will probably be augmented in the predictions that models are making. So We're talking about selection bias, device bias, label bias, misleading bias, and even model bias. So I was very happy to learn that the emergency medicine community has now released standards for the development of AI-based clinical decision support system in emergency medicine. And I would like to highlight two of the recommendations to finalize this talk. So one is that health inequity and bias should be acknowledged to exist in all data sets. So that is my take-home message for you. But also that data should be made anonymous and available for sharing. And that brings me back to our Amsterdam database, because that's available for all of you now. But having said that, I want to thank you for your attention, and I'm open for questions.
Thank you, Paul, and happy birthday. Are there any questions from the audience? Yes.
Doctor, I just want to ask, does the AI data already include the radiology and the blood chem for the patient series?
Sorry, can you say that again?
When they do the analysis, does the AI data already include the radiology picture of the series of subjects like that, or?
You mean the imaging data?
Yes, sir.
Yeah. So not for the models I presented just now. So there's certainly room for improvement. And I don't know if some of you saw the Max Harry-Well talk this morning. So everything in medicine is about context, right? So if we see a patient as a doctor, we kind of know intuitively, because we're also AI agents in a way, how this patient is doing, right? Because we see things, we smell things, we feel the surroundings, you see how other people interact. So I think unless AI will be able to capture that at some stage, but I think that will happen in the near future with cameras and all other sensors, then it will not be at a level that it can replace it, but it can certainly augment us.
There are certainly large language models that can use images as well, increasingly, although maybe not medical images.
But they're not that good at it, I would say.
No, not yet. So when will we have? We're saying that a lot of what happens to our patients beforehand is we don't know about, because we think they're important in hospital, but it's the primary care physicians. When can we look forward to an Amsterdam MCDB with primary care data in it as well?
Well, so if it would be up to me, it would be tomorrow. but between dreams and practical reality, there's a long way. So in Amsterdam, there's not one system for general practitioners. So it's probably going to take a while, although there are initiatives such as there's the Amsterdam Health Data Space, which is kind of a very mini version of the European Health Data Space. So when all caregivers are obliged to put their data in there, then we're going to get somewhere, but I would expect that only to be there in 2031 at the earliest.
Okay, I'll hold you to that. And one last comment, perhaps more seriously though, is that the large language models, they're obviously developed by various companies, not with medical applications necessarily in mind. And one of the difficulties of large language models is they can be very confidently wrong. They don't, they can be very confident about their hallucination or whatever is going on. And maybe is that something we want in AI? Do we want AI models that can tell us, look, actually, I'm not really sure about this. Is this an area we need to look at?
So I would say that it would be very useful to want that, so that we can estimate the uncertainty. There have been some initiatives trying to do that, and as you probably know, there's also some large language models out there that have been specifically developed or fine-tuned for the medical domain. So one example is the Gatortron, but the issue is, so if I'm perfectly honest, these models get outdated very fast, and I would be hesitant that we as a community, I mean, we would probably have the money, right? If all the governments would put their money together, we would be able to develop a medical large language model for the world. But I don't see that. I've been thinking this through a lot, and I don't think it's going to happen without commercial support. So we might be better off investing in our time trying to work together with these companies and teach them some habits that are ethical.
Brilliant. Thank you, Paul. I absolutely agree. Well, maybe one quick question? One very quick question, yes.
Michael Hessian from Sydney. Thanks very much for your talk. One of the problems, though, is what is the gold standard there? I saw that in triage, like we know that it's notoriously unreliable. And in one of those studies, certainly you were comparing the large language, the AI, with nurse triage. Well, in our place, nurse triage is very manipulated by their fear of missing a myocardial infarct or over-triaging, really, for example, in two different departments very close together. What are we measuring as the gold standard for triage here?
Yeah, so first of all, spot on. I thought I could get away with that, but obviously not. So indeed, the gold standard is currently usually nursing triage, and some of those studies were compared against that. So now my viewpoint is that it's probably better to have nursing triage than no triage at all, right? I hope that you would agree there. And having AI to help the nurses with that would probably increase the chances that they predict correctly, as you saw in the clinical trial, and that because the gold standard there was the final dispatch after the emergency department period of time. So I think if you would call that the gold standard, the final disposition, it's probably a more honest comparison.
Thank you. I think we're at time, so all that remains is to thank the speakers one more time and wish you an interesting afternoon.